Okay, so this is my ILS Cardioversion OSCE. We have been called to a 55-year-old male who's complaining of chest pain and they've collapsed. This patient has a history of hypertension and they've had a previous MI, but he does describe this feeling to be different. So our indications for a cardioversion are tachydysrhythmias such as VT, SVT, AF, and atrial flutter. Paramedics will do a electrical cardiovert, but it can be done with fluids. It's out of our scope. So our patient does have to be severely compromised, so that would involve hypotension, a unrecordable BP sometimes, absent pulses, and the inability to obey commands. So we want to consider differential diagnosis before shocking our patient, which could be hyperkalemia, tricyclic overdose, their history, SVT with aberrancy, so definitely things to consider. We want to do a full thorough assessment of our patient. They've got to look status 1, pale, clammy, just generally very unwell. We have done a thorough assessment, heart rate of 170, BP, hypertensive, 70 systolic. They're afebrile, so we're not thinking infection at the moment, and they're saturating at 86%, but we've got 15 liters of oxygen running through the rebreather. So before we cardiovert, we've got our bilateral IVs, we've got blood pressure cuff on, pre-oxygenation, we've got our two deep pads on, we've gathered a 12 lead already, and I've got my back valve mask ready, as well as my airway gear just in case our patient arrests. Now, I'm going to definitely confirm that my patient cannot obey commands. Can you squeeze my hand, please? You cannot squeeze my hand. So, because my patient is unconscious, I'm not going to administer ketamine, but we would usually, as a sedative and pain relief, usually 0.5 milligrams per kilo. We can also give fentanyl if they were conscious as a paramedic. So what I want to do is assess the patient. We've done that, gathered our vitals, and call for backup. Backup will be on the way. I'll now run through my cardioversion checklist.
Place pads in either apex or sternum or the anterior and posterior position.
Cool. So we've got our pads on here. We're not going to go anterior and posterior because we've got our 12 leads on.
Ensure the defib is in manual mode.
My defib is indeed in manual mode.
Select an R wave with the visible. Select a lead, with the visible R wave and ensure the R artifact is minimized.
Cool. What we're going to do is synchronize this.
So select synchronize mode.
Yep.
Confirm there is a detection symbol above every QRS.
Cool. So I do indeed have a detection symbol above each QRS. I would print it off, but the printer doesn't actually seem to be working, so I can visibly see them.
Cool. Ensure the patient has received adequate sedation if indicated.
Yep.
Select joules, charge the defib, and confirm everyone is clear.
Okay. So confirming it's at full 160 joules. Yep. Alright. Making sure everyone is clear. I'm going to hold down charge.
Cool. And then when you're ready, press and hold the shock button until the shock is delivered.
Cool. So looking at my patient, I'm going to hold the button, deliver the shock, and release.
Cool. And then determine the rhythm and the level of cardiovascular compromise.
Okay, so it doesn't look like we need to shock again. Our rhythm has actually changed from VT, but if we were If we remained in VT, we can shock again at 4 joules. Straight away, there's no time limit, but we would definitely have to reassess, gain another set of vitals. The patient would still have to be severely compromised. See if he can obey my commands. Other than that, we're gonna start transporting, either meeting our backup en route or straight to hospital. That is, yes, I believe.